My name's Tom Buchholz. I'm a radiation oncologist at Scripps MD Anderson, where I'm also the medical director of the Scripps MD Anderson Cancer Program. HER2/neu is an important biomarker in breast cancer. It certainly predicts responsiveness to effective systemic treatments. And today we have numerous anti-HER2 treatments that complement the effects of chemotherapy. How it should affect radiation decisions is an ongoing question. Specifically, we know that the majority of patients with HER2 positive disease will receive neoadjuvant chemotherapy or neoadjuvant combinations of chemotherapy and anti-HER2 therapy. And in this setting, we expect to have very high rates of pathologic response and very high rates of pathologic complete response. This translates to lower risks of local regional recurrence that sometimes may obviate the need for post-mastectomy radiation. How we decide about radiation decisions in the setting of neoadjuvant treatment is a complicated scenario. I think it's important to consider both the clinical stage of the disease or the extent of the disease before systemic treatments, and also the presence or absence of residual disease at the time of surgery or the pathologic stage after neoadjuvant treatments. And both of these two things are equally as important in the setting of HER2 positive disease or in other subcategories of breast cancer like triple negative disease. So I think HER2 is important because it has a much higher pathologic complete response rate. And accordingly, when we have pathologic complete response, we could consider not doing post-mastectomy radiation. Specifically, I've done a lot of research myself on this topic, and it was found that patients who present with clinical stage 1 or clinical stage 2 breast cancer who go on to have a pathologic complete response have relatively low risks of local regional recurrence. And this set the stage actually for a national randomized prospective trial that was conducted by the NRG Oncology. In this trial, patients with stage 2 or early stage 3 disease who achieve a pathologic complete response will be randomized to either no post-mastectomy radiation or post-mastectomy radiation. The results of this trial, unfortunately, are not available, although the trial did meet its accrual goal, and the results should be forthcoming in the years to come. But outside of the clinical study, we feel that if someone presents with stage 3 disease or locally advanced disease, say a T3N1 tumor, even in the setting of a pathologic complete response, we feel that post-mastectomy radiation is indicated. However, for someone with early stage disease or even T1N1 who receives anti-HER2 treatment in addition to chemotherapy, their likelihood of having a pathologic complete response is greater than having residual disease. And if they achieve a pathologic complete response, you certainly could consider withholding radiation. It's certainly a discussion to have with the patient. If, however, they have residual disease after chemotherapy and anti-HER2 neoadjuvant treatment, that would be a clear indication to commence with post-mastectomy radiation. So in general, how does HER2 affect decisions concerning post-mastectomy radiation? On the positive side, if you have you're going to have a higher rate of achieving a pathologic complete response to neoadjuvant treatment. On the negative side, if you continue to have residual disease despite neoadjuvant treatment with chemotherapy and anti-HER2, clearly that would be an indication for post-mastectomy radiation.